you have that account set up, then you're going to text your email address, and it has to be the email that you use to create your account, to this phone number. You'll get an automated response that says your phone number has been updated to add your cell phone number. Again, nobody's going to cold call you based on this. It's all secure and focused just on the CMEs. For each activity that you attend, it offers CMEs through this system. You'll just need an activity code. Our activity code today is 74659. And you text it to that same phone number. It's your sign-in sheet for today. And once you fill out your evaluation, you'll be ready to download your CME certificates and get your credits for today.
Do you see that Tammy has her hand up?
Yeah, this is the hard part about the thing I don't like about Zoom is that I have to stop sharing in order to be able to see. So Kara, I don't know, is it something that Kathy can address or?
I'm not sure. I think if you want to go ahead and unmute Tammy and ask your question, that might be the way to go. And Jamie, I do believe you're all on mute. I see that question.
So actually I can give Tammy talking permission. Tammy, you're all set if you want to unmute. And
I'm sorry, I have no idea why that is up. I have no clue.
Okay, well, we can lower your hand.
Okay, thank you.
You were just stretching, no right? Just stretching.
Good. Yes, so everybody should be pretty much muted, and yes, we understand that people have lives other than this. So as there's babies and dogs and cats, they all like to get in on the Zoom action here. So I know that people are still joining. I'm gonna go ahead and just pull up the CME information one more time, and then we will get started shortly. So for those of you who already have an iCloud CME account through MaineHealth, you can ignore me for this slide. If you don't already have a MaineHealth iCloud CME account, you'll need to create one in order to get your continuing education credits for today. The good news is that MaineHealth has joint accreditation, and so this will be one-stop shopping for CMEs and nursing contact hours in the near future. So go ahead and create your account. Once you have your account, you're going to send a text message to the phone number on the screen here. You'll need to text the email address that you use to create your Cloud CME account. You'll get an automated reply that your phone number has been updated to include your cell phone number. And then for each program that you attend where there's an offering of CMEs or nursing contact hours, you'll need the activity code. You'll text that activity code to that same phone number, and that's our sign-in sheet for today. Every activity is going to have a different code, so you'll just need to pay attention to that at the start of education programs. So with that, we're close to 12 noon. I'm gonna stop sharing and give Kara a chance to get set up. So Kathy, we've got one comment that they tried to do this and it said they could not take my number. So follow up with that person. I think you can see the chat there. So welcome everyone. I know people are still joining. This is the second in our series, in our breastfeeding webinar series. The first topic was around communications and messaging, and that is currently up on the Perinatal Outreach Education website. If you need that link, you can email Kathy Taylor and she'll send you the information on how to access that recorded webinar. Our topic today is a popular one. I know that over the years that I've been doing this job, we get many questions about marijuana and pregnancy and breastfeeding. And I'm thrilled to have Kara has worked hard on this presentation and put together a lot of really great information and tools for you today. So with that, I'm going to turn it over to Kara Kaikini.
Hello, everyone. I'm happy to be here today to talk about this topic. So my name is Kara Kaikini. I'm the breastfeeding consultant for Maine's Perinatal Outreach Education and Consultation Services Program. Here is our disclosure slide saying that we have no disclosures. And the learning objectives for today are, we're hoping that by the end of the webinar, you'll be able to explain the recommendations for marijuana use in the perinatal period, identify the current data related to marijuana use in Maine, and demonstrate ways to discuss and educate new and expectant parents about breastfeeding and marijuana use. So we'll start with statements and recommendations from organizations in the United States. I'll start with the AAP because this is the go-to organization when we look at practices affecting babies. They recommend that all women should be counseled not to use during pregnancy, and it should be discouraged during lactation because there is insufficient data to assess the effects of exposure on infants. Limited data reveal that THC does transfer into human milk, but there is no evidence for the safety or harm of marijuana use during lactation. Therefore, women need to be counseled about what is known about the adverse effects of THC on brain development during early infancy, when brain development and growth are rapid. They suggest that marijuana can be included as part of a discussion about the use of tobacco, alcohol, and other drugs and medications during pregnancy, and that providers should emphasize that the purpose of screening is to allow treatment of the woman's substance use, not to punish or prosecute her, and we will talk more about that later. The American College of Obstetricians and Gynecologists say that there are insufficient data to evaluate the effects of marijuana use on infants during lactation and breastfeeding, and in the absence of such data, marijuana use is discouraged. The CDC also has several web pages with information about the potential risks of using marijuana while breastfeeding. These links are in the resources section of this presentation, which you will all have access to after. And here it states that using marijuana while breastfeeding can allow harmful chemicals to pass from the mother to the infant. Breastfeeding mothers should not use marijuana or CBD in any form. And it does state that data are insufficient to say whether or not it is safe for mothers who use marijuana to breastfeed. It also explains potential risks and theoretical concerns. The FDA also has a statement against using cannabis, including CBD, when pregnant or breastfeeding. And the Academy of Breastfeeding Medicine put out guidelines in 2015 for breastfeeding and substance use disorder. They recommend that for occasional or rare users, that they should be counseled to avoid or reduce further use while breastfeeding, and they should be advised to its possible long-term neurobehavioral effects. And also that they should be instructed to avoid direct exposure of the infant to marijuana and its smoke, and to share the benefits of breastfeeding. So that's mentioned in particular because some women will choose simply to feed formula in order to continue using marijuana or to avoid involvement from Child and Family Services. If they're not also educated on the benefits of breast milk and breastfeeding, this may seem like the best choice or the most obvious choice for them, which is why we need to continue to educate on the importance and the benefits of breastfeeding. So they break their statement up into occasional or rare users and moderate or chronic users. And for those, they say that abstaining from marijuana use is warranted, and that data are not strong enough to recommend not breastfeeding with any marijuana use, but that providers should urge caution instead. The National Association of Neonatal Nurses recently shared their statement, and they cited several organizations when saying that due to insufficient and limited data, we're seeing a theme here, marijuana use should strongly be discouraged by breastfeeding mothers. And they also said that those mothers who choose to continue to use should be advised to significantly reduce their intake and be informed of possible adverse effects on infant development. They also include in their statement that when mother's own milk is unavailable, the use of donor human milk should be considered. And when donor human milk is utilized, it should be obtained from a reputable human milk bank program that screens for marijuana and other illicit drugs. They go on to highlight the role of the nurse when it comes to speaking to patients about marijuana use, and they emphasize that it is important to provide non-judgmental education, support, and active counseling to all lactating women, no matter what their use should be. They should participate in developing evidence-based, non-judgmental, and non-punitive hospital, state, and national guidelines addressing marijuana use during lactation. They also say it's important to be knowledgeable of state and local requirements regarding the involvement of human services and to advocate for evidence-based marketing of marijuana products. So just like there is misleading marketing of infant formula, there's also misleading marketing of marijuana, specifically marketing it as a way to alleviate discomforts of pregnancy. This also means that being involved in legislative and public health initiatives that raise awareness about this is important, and to participate in further research about maternal use of marijuana or lead that research. So that's certainly an option for you in your institution as well. I would encourage that. So now for the science and research on this topic that inform all of those guidelines. So first, let's start with what marijuana is. It is the most used drug in the United States as of 2015, and 53% of marijuana users are millennials. There are over 480 natural components found within the cannabis sativa plant, of which 66 have been classified as cannabinoids. And the most well-known in research of these is THC, or delta-9 tetrahydrocannabinol. This is the substance that's primarily responsible for the psychoactive effects of cannabis. CBD is probably the most abundant cannabinoid, contributing up to 40% of cannabis resin. And CBD may have anti-anxiety effects and lessen the psychoactive effects of THC. This means that a plant with a greater percentage of CBD may reduce the intensity of the effects of THC, which in effect lowers the potency of the plant. So it's important to know that today's marijuana is genetically engineered to produce either high levels of CBD for medical qualities or high THC for psychotropic qualities, making it much stronger than anything around in the 60s or 70s when some research was done. And as you can imagine, these combinations vary widely and make this topic quite difficult to research or to trust anecdotal reports. Use is not approved by the FDA, and the federal government currently classifies marijuana as a Schedule I controlled substance. In other words, the federal government views marijuana to be a drug with a high potential for abuse and a lack of medical value, quote unquote. However, 15 states and 3 territories now have approved regulations for cannabis for adult use, and a total of 36 states, District of Columbia, Guam, Puerto Rico, and the US Virgin Islands have approved comprehensive publicly available medical marijuana and cannabis programs. In Maine, it is legal for recreational and medical uses. You must be 21 or older, in possession of 2.5 ounces or less, or 2.5 ounces of marijuana and marijuana concentrate that includes no more than 5 grams of concentrate. It is illegal to consume it in public spaces, and it is illegal to operate under the influence. There's a long list of regulations listed at that website there. And cannabis can be inhaled or ingested and is most often used for anxiety, nausea, and vomiting in pregnancy. Medical marijuana has been allowed in Maine since 1999, but changing laws in 2009 allowed for dispensaries. There are currently 7 medical marijuana dispensaries listed on the state of Maine website, and currently 6.7% of adults in Maine have a certificate for medical marijuana. 2019 report from Maine's Office of Marijuana Policy shows that since 2018, the number of printed patient certifications increased 42.3%. And here's a list of the diagnoses for which medical marijuana is prescribed in Maine. In order to become a medical marijuana patient and get a card, a person must have a qualifying chronic health condition, find a doctor who can provide a recommendation, complete a medical marijuana program application, and show government-issued ID and proof of residency. In terms of nausea and vomiting, it is helpful to understand how THC works in the brain versus the digestive tract. So in the brain, marijuana helps prevent nausea and vomiting. That is one reason why it's often recommended for stopping such symptoms in people having chemotherapy, for instance. But in the digestive tract, marijuana seems to have the opposite effect. It can actually make you more likely to have nausea and vomiting. With the first use of marijuana, the signals from the brain may be more important. That may lead to anti-nausea effects at first. But with repeated use of marijuana, certain receptors in the brain may stop responding to the drug in the same way. That may cause the repeated bouts of vomiting found in people with something called cannabinoid hyperemesis syndrome, or CHS. It still isn't clear why some heavy marijuana users get the syndrome, but others don't. There's no single test to confirm the diagnosis. The only way to know is if there's improvement after quitting. Symptoms are usually eased after a day or two, unless marijuana is used before that time. And treatment may include IV fluid to replace dehydration, medicines to help decrease vomiting, pain medicine, frequent hot showers has been found to help as well. And to get fully better, complete cessation of marijuana use altogether is required. Some people may get help from drug rehab programs to help them quit. Cognitive behavioral therapy or family therapy can also help. And if marijuana use has stopped, symptoms should not come back. So research that was published just a few years ago by the American Journal of Obstetrics and Gynecology found that THC does cross the placenta, and the half-life of THC varies from 20 to 36 hours in occasional users to 4 to 5 days in heavy users, and may require up to 30 days for complete excretion. In animal models, THC produced fetal plasma levels that were approximately 10% of maternal levels after acute exposure, and significantly higher fetal concentrations were observed after repetitive exposures. The conclusion stated that maternal marijuana use was not associated with a composite of small for gestational age, spontaneous preterm birth, or hypertensive disorders of pregnancy. However, it was associated with a significant increased risk of neonatal morbidity. And factors that were more frequent in babies of marijuana users were infection morbidity and neurological morbidity. After adjustment for tobacco, race, and other illicit drug use, marijuana use was still associated with composite neonatal morbidity or death. Knowing that there can be negative effects of using marijuana during pregnancy, some might wonder what exactly is the cause of potential negative effects on an infant. The AAP even states that, quote, it can be difficult to determine whether effects of the drug on the infant are attributable to exposure during pregnancy or from breastfeeding. And the authors of one study quoted in the AAP statement said that a major limitation of their study was their inability to determine the independent effect of marijuana, given that most of the studies assessed did not exclude individuals with polysubstance use, including tobacco or alcohol, or measure use of those substances. The authors also cited additional limitations, such as how the use of marijuana was identified mainly by self-report, and few of the outcomes assessed were standardized across studies. In addition to likely exposure during pregnancy, other potential confounding factors are that the mother's ability to care for her infant may be impaired because of her use. Infants can also be exposed to marijuana through inhalation of the smoke. And 50% of marijuana users are also tobacco users. So it's possible that the damage or risk is due to tobacco. And marijuana users have also been found to be more likely to use illicit drugs and alcohol, with a significant linear dose response relationship between the use of marijuana and alcohol. And in Tori Metz's review article, cited here, she states that existing studies are plagued with confounding factors like tobacco and other drug exposures, as well as sociodemographic factors. In addition, there's a lack of quantification of marijuana exposure by the trimester of use, and a lack of corroboration of maternal self-report with the biological sampling, which can affect results. So this research can be really tricky. A couple of months ago, I came across this article about how those who are breastfeeding and pregnant are often grouped together in government guidelines when talking about COVID vaccine safety. And those of us who work in the perinatal field know this isn't just limited to vaccine safety. Guidelines about marijuana use in pregnancy and lactation are also grouped together. As I state in the article though, it is helpful to acknowledge that getting vaccinated during pregnancy and lactation carry different theoretical risks and potential benefits. One of the doctors cited said it's never a good idea to lump together pregnancy and breastfeeding when asking whether something is harmful, and that some drugs are risky in pregnancy are also avoided by people who are breastfeeding, even when they're perfectly safe for a nursing baby. Another doctor was quoted saying that even if a drug or vaccine does end up in breast milk, its journey to the baby isn't done, which is different than during pregnancy. Anything that goes through the breast milk also then has to go through the infant's gut. So this is true for marijuana as well. First, the mother inhales or ingests marijuana, then it is absorbed into the mother's bloodstream. Plasma then carries the blood components throughout the body, and medication or drug components enter the adipose tissue, whose main role or function is to collect, store, and then release lipids. THC slowly leaks out of the adipose tissue to the rest of the body, including urine and including breast milk. Dr. Thomas Hale explains that cannabis likes the liver. He said 95 to 99% gets to the liver and is not passed to the plasma. Most goes to fat tissue and leaks out over periods of time. So THC either gets metabolized by the liver or goes to fatty tissue and is barely detectable in plasma. He also explains that kidneys concentrate plasma 70-fold to make urine. And drug screen positive means you only have enough in your urine to get a positive test. It doesn't mean that it's in the plasma or the breast milk. Plasma and milk will be negative long before urine levels are negative. He says that if it's there in mom's adipose tissue, it's not doing anything. Some may be in the brain tissue, but it's low. It goes from the brain to the adipose quickly. He said fat is a big sink. It's a useful sink, but sometimes drugs that we want to go to the brain, we can't get out of the fat. Part of the discovery process in pharmacology research is how to get it out of the fat. We want to keep it in the plasma or the brain. That's not the case for marijuana in particular, but it is really interesting to understand how this process works. Dr. Hale is a professor of pediatrics and associate dean of research at Texas Tech University and is considered one of the foremost experts in the field of perinatal pharmacology and the use of medications by pregnant and breastfeeding mothers. He has spent over 25 years collecting data on many current medications and their use in breastfeeding, categorizing them on a scale of L1, compatible, through L5, hazardous. He publishes a book with this information called Medications in Mother's Milk. It is updated regularly and is thick. There's actually an old copy under my laptop right now. It's definitely helping to hold my laptop up. The current edition is 736 pages, and new to the 2021 edition are 50 new drugs, 356 drugs updated with new data, and 817 drug references updated. Cannabis is considered potentially hazardous, which is defined as positive evidence of risk to a breastfed infant or to breast milk production, but the benefits from use in breastfed mothers may be acceptable despite the risk to the infant. It says that while this data poses numerous limitations and does not directly examine the benefits of breast milk versus risks of exposure to marijuana in the milk, cannabis use in breastfeeding mothers should be discouraged at this time. And that healthcare professionals should encourage alternative treatment options for maternal health conditions requiring the use of marijuana. Dr. Hale is also the executive director of the Infant Risk Center, which is a call center where professionals and parents can call an 800 number to ask about a medication and whether or not research has shown if it is compatible with pregnancy or breastfeeding. And a blog post on his website shares the challenges of doing research on cannabis and breast milk. He says that doing research with cannabis products is virtually impossible in the USA today. The effect of all the governmental legal restrictions virtually stops all research. He said, we were most fortunate to find a wonderfully supportive group of lactation consultants and cannabis using moms in Colorado who helped us find breastfeeding mothers who were using this product while breastfeeding. And, oh, hold on. Yeah, I think that's it. And here is that study. So Dr. Hale worked with another researcher, Dr. Teresa Baker, both from Texas Tech, to study the transfer of THC into breast milk. And they located 8 women, it's a small sample, who considered themselves occasional marijuana users and were currently exclusively breastfeeding an infant. The test subjects anonymously picked up packages containing exact instructions on how to participate in the study, where to get the marijuana, and how much to smoke. And marijuana used by all subjects had the same strength of THC and CBD. After 24 hours without marijuana, each woman was instructed to collect a baseline breast milk sample and then inhale a dose of 0.1 grams of cannabis containing more than 23% THC. After consuming the dose, they expressed samples of their breast milk at 4 different stages, at 20 minutes, 1 hour, 2 hours, and then 4 hours later, froze them and mailed them to Amarillo, Texas for testing. At all 4 points, the researchers found low levels of THC concentrations in the breast milk. They found that the infants ingested an estimated mean of 2.5% of the maternal THC dose, which they classified as a low concentration. Their range was also wide. You can see that's 0.4 to 8.7%. They also concluded that the long-term neurobehavioral effect of exposure to THC on the developing brain is unclear. So mothers should be cautious using cannabis during pregnancy and breastfeeding. He summarized this on his website, saying that what it suggests to us is that THC does transfer into human milk, and it is apparently a function of the daily use in mothers. We think that in occasional users, the level of transfer is minimal, about 2.5% or lower. We also surmise that in heavy users, it could be 3 times this dose. This is probably a function of the filling of the adipose sites with chronic daily use. And once these fat sites are full of THC, less is transferred out to the fat tissues following smoking, thus leaving more in the plasma compartment to then transfer into the milk. We strongly urge cannabis using moms to avoid using these products while breastfeeding, as we simply do not know what happens neurobehaviorally to these exposed infants. This study, published in 2018 in Pediatrics, looked at 54 breast milk samples from 50 women. These were sent to a research repository called Mommy's Milk at the University of California, San Diego. And after providing written informed consent, they recalled their exposures for the 14 days before milk sample collection and provided additional information on exposure to herbal supplements, prescription medications, or recreational substances since giving birth. Women were instructed to pump and collect 50 milliliters of milk up to a full expression the time of the scheduled interview as possible, and up to 24 hours before. Here, THC was detectable in 34 or 63% of the samples up to about 6 days after the last reported use. Median concentrations of THC was 9.47.
And we've lost Kara here. I think Kara has frozen. Hopefully she will come back momentarily here. So there is a question on the chat box, but does Thomas Hale define occasional and regular use? And we'll ask Kara that when she comes back. So, Kara, great. Glad you made it back.
Yeah.
That's okay.
I hope I wasn't gone very long.
No, I don't think you were, but there was a question that came in about, does Dr. Hale define occasional and regular use? So
that's a great question, and I don't recall off the top of my head about that. So I need to get back to sharing my screen here. Okay, can you hear me okay and see my screen okay?
Yes, you're good.
Okay, sorry about that. Let's see here. I think I was just saying that there are a number of different factors like the extent of oral absorption in breastfeeding infants, metabolism and accumulation patterns, and pharmacologic effects of even low levels of cannabinoids on neurodevelopment. That's all unknown and require further study. So I want to do a poll here. Let me see if I can do this. Just need to get my cursor in the right spot. Here we go. I'm going to launch the polling here. Hopefully you can all see this. So the question is, what percentage of new mothers are reported on their PRAM survey that they use marijuana after their baby was born? And the PRAM survey is the Pregnancy Response and Monitoring Survey, I think. And that they usually are taking this within the first 5 or 6 months after the baby's born. So I'll give it another minute for responses to come through. And then I'll show you the results. Okay, about 80% of you have voted. Okay, I think I'm going to end that here. Got 84%. And then I should be able to launch it. So I'm going to end it and then share results, I mean. Okay, so it looks like you should all be able to see that. Can you see that?
Yes, it's working.
Okay. So the majority is close here, but the majority of you guessed that about 8.3% of mothers reported using marijuana after their baby was born, with a close second of 12.8%, 18.1%, and then 3.9%. Okay, I'm gonna minimize that. So next we're going to talk about data. All right, everything good? You can just see my screen?
No, if you can you click the blue button that says stop share results?
Oh yeah, let me see here if I can get that back again. Okay, bear with me here. Polls. Okay, stop share results. I'm gonna close it. Is it gone?
No, you might need to stop sharing and then restart the sharing. I'm still seeing the poll up.
Okay. So let me try closing it again. Is it still there? Because I don't have it on my screen.
Yeah, it's
Oh,
gone.
okay.
It's okay.
Someone left a note saying you can close it yourself. Okay.
Yep.
All right, so you should see the screen. Excellent. So this is recently released PRAMS data from 2019. And it's not significantly different than the data from 2016 to 2018. But it shows that 27% of women reported using marijuana before pregnancy, and 9.9% reported during pregnancy, and 12.8% reported using since their baby was born. And the demographics of the users tended to be mothers of a younger age, lower income, unmarried, on WIC, Medicaid, and they were more likely to have a baby with a lower birth weight. And a study that just came to my email yesterday showed that cannabis use increased significantly among women before pregnancy and after pregnancy, but not during pregnancy, in states that had legalized recreational cannabis compared with states that had not legalized cannabis. So this is really an important topic to be talking about, the postpartum period and the potential risks of using marijuana. Maine Health data also recently was gathered and shows that of the perinatal patients through the Maine Health system who were diagnosed with opiate use disorder, 62% also reported using marijuana. The Maine Family First Prevention Services State Plan released last month shared substance exposed or affected infant notification rates by county in Maine. And the report states that Maine has seen an increasing trend since 2012 of babies born substance exposed or affected. The state rate's currently at a little over 7%. In 2019, 1 in 13 babies were born in Maine substance exposed or affected. And in addition, the number of babies born affected or exposed exceeded 10% in 8 of Maine's 16 counties, with these top 6 counties identified here. And this may, for those of you who, I think we have people from all over the state on this call here, and from all of these counties probably, so you might recognize and understand these statistics. You can see the highest rate is in Somerset County. PRAMS data also shows that the highest rates of postpartum marijuana use in Maine are in the Somerset and Kennebec Public Health District, in Oxford, Franklin, and Androscoggin, and the lowest rates in Cumberland and Aroostook. So of course we want this data to be as accurate as possible. We know that it might not be, probably isn't 100% accurate. And data are only as good as the screening, which is often only as good as counseling skills. So that's what we're going to talk about next. The PRAMS survey also asks if a prenatal provider asked if they were using illicit drugs such as marijuana, cocaine, crack, or meth. Yes, those are all grouped together. And good news is that 90% of the respondents said yes in 2019 that they were asked. ACOG specifically advises against routine urine tox testing in pregnancy, but recommends that routine screening is done prenatally. And they suggest using tools like the CRAFT, which is a adolescent substance use screener, or the 4Ps. And the 4Ps is a screening instrument designed specifically for pregnant women. And it screens for alcohol, tobacco, marijuana, and illicit drug use. And the questions are, did any of your parents have a problem with alcohol or other drug use? Does your partner have a problem with alcohol or drug use? In the past, have you had difficulties in your life because of alcohol or other drugs, including prescription meds? And in the past month, have you drunk any alcohol or used any other drugs? And any yes answer should trigger further questions. So in asking screening questions, you may want to say something like this. We are screening every pregnant parent for substance use, even if it is legal, like marijuana and alcohol. We aren't screening or reporting to punish or prosecute you, but to have the opportunity to share what we know about potential risks, recognize and identify any needs you have, and to offer some other options. And you can also share that as of January of this year, a plan of safe care will be created for any infant substance exposed and or affected and the surrounding family living with substance use disorder. So a substance exposed infant is any infant exposed to substances, legal or illegal, and should be reported. And yes, it can certainly be messy and challenging knowing whether to report one exposure versus daily exposures. As we've talked about already, the amount of exposure can make a difference. But we simply need more information about short-term and long-term effects on cannabis in order to make any other recommendation. In the absence of this data, the recommendation is to abstain or avoid marijuana. And Office of Child and Family Services is working on a statement about this, so stay tuned. And in the meantime, if you have any questions about the plan of safe care and are looking for training opportunities, I'm guessing several of you have already attended some of this training. I know they're working really hard to roll that out. You can reach out to these folks here. And it may also be helpful to understand the process a parent can expect if a report is made. So in addition to a plan of safe care being created, the Office of Child and Family Services assigns substance exposed infant reports, either a child welfare investigation or a referral to partners such as public health nursing and or Maine Families Home Visitors, which is usually done through a referral to Cradle Me. And again, it can be emphasized that reports aren't made to punish or prosecute them, but to better learn services or interventions that may be helpful for their family's well-being and to take steps to implement them. So trust is the currency of public health. This is a quote from Julia Marcus, who was quoted in an article in the New York Times recently when talking about absolutism regarding the COVID emergency. And the article explains that in a public health emergency, absolutism is a very tempting response, that people should cease all behavior that creates additional risk. When it comes to COVID, the examples they were sharing were of people yelling at joggers for not wearing masks or deciding to ban any and all outdoor exercise. And the question still often remains, how much are these tactics reducing the spread? Are there any downsides to this kind of absolutism or absolutist strategy? And this is when many would argue that the risk reduction approach or harm reduction is more effective than absolutism approach when addressing any public health emergency or concern, including marijuana use during the prenatal period. So the first step in a risk reduction approach is to build that trust, the currency of public health. I like that. Not only do we want parents to trust us, they want us to trust them. So sometimes we need to trust that mothers are doing what they think is best for themselves and their babies, and empathize with them in their situations leading up to their decisions. If we know her decisions aren't evidence-based, it is up to us to then provide her with the most accurate information. And then you can go back to trusting yourself that what you've done what you can to help her make an informed choice and to document it. Building trust can be done through judgment-free conversations, paying attention to tone and language, so very important, that acknowledge their challenges and ultimately lead to informed choice. So empathizing with her challenges, then sharing information and discussing solutions that may be more successful if they include risk mediation. We can give them practical suggestions to help make the safe choice easier in those challenging times. Simply starting with warnings and telling them to stop immediately is not helpful in building trust that is necessary for authentic conversations and information sharing on their part, which we need to have. And we need to remember to document these conversations, what information you shared and what her choice ended up being. So this process may include motivational interviewing, and the basis behind MI is that change or making a different choice is most effective and most sustainable when individuals choose to make the change because they've realized it supports their goals. One motivational interviewing technique is called the love technique, and this is essentially an empathetic conversational approach. I'm wondering, sorry to pause here, I'm going to hit record because I'm not sure we started recording again. So I'm going to pick it up from here, the recording. I'm not sure why I thought of that, but I think that wasn't happening. Okay. So one motivational interviewing technique is called the love technique. And this is essentially an empathetic conversational approach. So this includes listening to what the families are saying, asking open-ended questions, validating her feelings, and providing targeted education that addresses her concerns. So these steps all help build her autonomy and her agency, which will ultimately help her make safe decisions. And this conversational approach can also be considered an autonomy enhancing dialogue. So I think that we talk about conversational approaches and how helpful those can be. I really like the term an autonomy enhancing dialogue is going to be helpful for that trust that's going both ways. So as we've already seen, a common theme is asking open-ended questions. And some examples of open-ended questions could be, what are your plans for feeding your baby? That's a good way to start prenatally. What do you know about breastfeeding? And marijuana. You may find that she considers marijuana as safe as herbs like fenugreek, blessed thistle, and others that are often recommended or accepted for enhancing milk supply, even though we don't know the efficacy or safety, and it's not regulated by the FDA. So oftentimes moms can loop the marijuana herb in with these other herbs as well. And this is good to understand what her understanding is. What do you know about recommendations regarding breastfeeding and cannabis? How do you feel about them? What are your biggest concerns about being able to meet them? And you may hear them say that they'll just pump and dump. And this is a great teaching opportunity for explaining the difference in the metabolization of alcohol and marijuana. Pumping and dumping is not an effective technique or strategy for removing THC because it does stain the fat. It is metabolized very different than alcohol. So pumping and dumping after using marijuana is not going to be effective. We don't actually really know how, I mean, there might be a period of time that she would have to pump and dump before it's totally out of her system, but that is something we don't know. And asking, can you tell me? Can you tell me more? So can you tell me, why are you using? Of course, this is a really important question. They may share that they use to help with breastfeeding, actually. They might be doing that to specifically stimulate their appetite if they feel like they need help bringing in more calories, or it might help them to relax, which can then help with their letdown. They may use it for pain relief after childbirth, or to reduce stress associated with new parenting or breastfeeding itself. I think anyone who's had a new baby knows it can be very stressful, and breastfeeding certainly can be as well. Tell me more is always a great question. And so you can also ask, what are some other alternatives you've tried or considered? And go from there. So when counseling women about this topic, it's recommended that you share the statements and recommendations we went over earlier from the National Association of Neonatal Nurses, the Centers for Disease Control, et cetera. And then you can add, we don't have all the research we'd like on the effects of marijuana in breast milk on growing infants, but we do know that cannabis contains over 400 different chemical components and 60 pharmacologically active cannabinoids like THC and CBD. Those are only 2 of them. THC does enter breast milk, we know that. And we also know that THC is stored in fatty tissue like the brain, liver, muscle, and spleen, and then delivered to the bloodstream from there. So the baby can be exposed over a period of time. It's also okay and really recommended to share what we don't know. So we don't know what long-term effects could be when using while breastfeeding. We don't know this yet because studies are few and old and have limitations. And there are many variables in studying this, like the amount of THC ingested, other substances ingested, et cetera. And there are epidemiological and animal data showing concerns regarding both short-term growth and long-term neurodevelopmental and behavioral consequences of prenatal exposure to marijuana. But we don't have data on the effects of THC in breast milk. There are, however, theoretical justifications for a potential negative effect of THC in breast milk on the infant. And when we don't know the effects of a possibly unsafe chemical, we suggest avoiding. We also don't know how long THC remains in the breast milk or when it's safe to resume breastfeeding after use, which is why the pumping and dumping question is tough as well. And we also don't know about other components in marijuana like CBD or anything about what other additives might be in what is inhaled or ingested, or whether there are contaminants like fungi, pesticides, or heavy metals, and whether those could impact the baby. And remember, again, once you educate, always be sure to document what information you're given, what kind of conversation you've had. You can document, you shared what you know, you shared what we don't know. And so she can truly make an informed choice. So I became a new mother for the first time 9 years ago, but I'm still part of several new mother groups on Facebook. And it's mostly to keep me in the loop about what new families are talking about. For instance, I saw this question come up: weed and breastfeeding, what are your thoughts? And I thought, ooh, this is timely. I think this was back in November when I knew I'd be talking about this in March. There were 111 comments, and many were like these. Absolutely fine. My baby girl is perfect, and I smoked during the whole thing. It was the only way I could keep food down and get some sleep. One of my doctors tried to tell me it causes behavior problems later in life, but honestly, I don't see how that could be. That most teens act out because of hormones and growing up. Another person said, my personal thoughts are, why add anything that isn't good for them? But that is my thinking. And then this person said, I highly recommend joining Breastfed Cannababies. They have files with actual research. And there were quite a few people who recommended this group. So I looked into it and I saw that there were about 33,000 members. I decided to join it. They ask you if you're pregnant, breastfeeding, or just want to learn more. So I selected that one, and I continue to be educated about what questions, concerns, beliefs, and information is out there in the new mom community regarding this topic. There are also questions about whether people think it's safer to take Zoloft or use marijuana for anxiety in particular. And comments range from Zoloft helps me, but I still use marijuana. Or I stopped using marijuana when I got pregnant and started Zoloft instead. Or I stopped using Zoloft when I got pregnant and started smoking once I got pregnant. And someone else said Zoloft has so many harmful chemicals in it. So I share this because it's helpful to know what parents are using as an educational resource and to emphasize the importance of them also getting evidence-based information from their providers prenatally and postnatally. So there's so many potential scenarios out there that many of you are encountering on a day-to-day basis, and I do hope we will have some time at the end for you to ask questions, share thoughts, hopefully have some sort of a discussion here. But some some situations that I know you're encountering might be in a prenatal visit where a mom reports using either occasionally or heavily. Maybe you are encountering this mom in the hospital after birth where she's reporting using occasionally or heavily. Maybe in the hospital she's had a positive urine screen, but maybe reports different usage. You may be encountering this mom in the NICU. We'll talk about that in a second. And in the postpartum visit, you might see her in a pediatric setting where she's reporting using heavily or occasionally. And we've already learned today that the amount the baby receives is likely a function of the dose mom is receiving based on many factors like the frequency and duration and the kind of cannabis she's using. Still, there's so much we don't know, and our guidance should be consistent based on the information we do have. So it's, again, reiterating that the recommendation is that you do breastfeed, and it's not recommended to use marijuana. So these may also be common questions or concerns you've heard too. You might hear, there's not much research on the effects of THC on the baby. Is there much research on anti-anxiety medicine and breast milk? And you can respond saying something like, yes, LactMed is a great resource to look at research on medications in breast milk. And there's quite a bit of research showing the safety of anti-anxiety medications like Zoloft and breast milk. LactMed also has information on cannabis too. You may hear, I heard that it's better for babies to get some Suboxone through their mom's milk to help with withdrawal. Would that be true for marijuana too? You can say, we just don't know this. There may be some theoretical guesses around this, but we just don't know. And it's always best to monitor baby for any symptoms if there's any sort of medication or drug that has been ingested. And someone might say, well, I'll just use formula. That must be safer, and I don't want any reports to be made. You can say breast milk is recommended and it's considered better than formula for many reasons. It's not necessarily safer to use formula. And when a report is made, and you can, again, explain what happens when a report is made and that it's done not to punish them, but to see what kind of services might be helpful for them. The AAP statement actually addresses the concern of marijuana in preterm milk in particular. I know some of you are concerned about this in particular. And the AAP just says, expressed maternal milk has been shown to significantly improve outcomes in preterm infants by decreasing the rate of necrotizing enterocolitis, contributing to earlier attainment of full enteral feeds, decreasing the rate of sepsis, and improving neurodevelopmental outcomes, et cetera. They stop there, but it does support other suggestions that giving breast milk with some THC may still be better than not giving any breast milk, especially in preterm or ill infants who benefit the most from breast milk. Which leads me to this article. This is an excellent article written by a philosophy professor, actually at the University of Maine. Her name's Jessica Miller, about the ethical issues of maternal marijuana use. I highly recommend you read this on your own as well, since I think this can be a particularly tough topic for some people. And she says that the complex legal situation and gaps in scientific understanding leave clinicians with uncertainties about how to best promote beneficence, non-maleficence, and respect for autonomy, and justice and fairness for mothers and babies in the breastfeeding context. These are all ethical obligations of healthcare providers: beneficence, non-maleficence, respect, etc. So she talks about how providers can actually alleviate patients' worries by being transparent about their medical concerns and also sharing their legal and ethical duty to report. That they have a responsibility to understand the legal context and transparently explain it when necessary, explain their reporting requirements, and to also balance risks and benefits in order to promote good health outcomes for both mom and baby. And that goes back to the trust that we were talking about, is that being transparent is going to be very helpful. She emphasizes much of what the National Association of Neonatal Nurses said in their statement too, that it's important to have clear hospital policies that may include a transparent decision matrix for determining whether the risk of providing mother's own milk is outweighed by the benefits for a particular patient. And she speaks about how clinical uncertainty can create openings for unconscious biases to influence the attitudes of providers. And she argues that admitting that uncertainty, that we don't have a lot of information, can help increase the patient's trust and autonomy. In addition to unconscious bias, she speaks about the loss-gain framing bias, which is the tendency to view losses as larger than gains, which may lead clinicians to overvalue the avoidance of harms from THC in breast milk relative to the gain in continuing to breastfeed over substituting with formula. So there's a lot in there, a lot to consider for sure. So a goal of this webinar is to provide resources for you to share with your patients, and these can be helpful for fellow providers to learn from too. So these can be really great documents to use in addition to the conversations and all those questions that you could be asking them. And this education needs to start prenatally, not only because THC can impact the fetus, but because parents need to be informed before their babies are born about what happens once the baby's born. So this is from ACOG, and it is focused mostly on pregnancy, but does also speak a bit about breastfeeding. Same thing, this handout from the CDC focused on pregnancy, but also has some info about breastfeeding. And the Prevention Connection in California recently shared this excellent video about cannabis in pregnancy and lactation. It's about 4 minutes long, and we're not going to watch it now, but it is definitely worth the watch. So these resources will all be available for you to have after. You may already be familiar with the Maine Prevention Store and this handout about marijuana and whether it's safe with when breastfeeding. So that is still an option. Those are free and can be ordered through that Maine Prevention Store site. And here we have goodtoknowmaine.com. This is a really helpful resource. It's really easy to read, really user-friendly, and has great information about marijuana and how it can affect pregnant and breastfeeding women. This is also another fabulous handout created by Healthy Androscoggin in partnership with Maine Prevention Services. And if you'd like a copy, you can contact Corey Brown at that email address. I don't believe it's available online yet, but she can send you copies to print. And I really appreciate how at the bottom it says, make the safest choice for your baby. Choose not to use cannabis while pregnant or breastfeeding. Instead of saying don't use, it's kind of putting that power in their hands again to make a safe choice. And this comes from the Colorado Department of Public Health. They've had legalized marijuana for quite a while, and so they've had quite a bit of time to provide education on this. So this is another option. It's another PDF, two-sided, that you can use. And if handouts and websites aren't the most effective for the people you work with, apps maybe. And the Infant Risk Center and LactMed both have apps for parents and providers to look up those risk ratings and share what research has been done. And they might appreciate having the time to read that on their own from reputable sources. We want to give them those reputable sources. So here are some of those resources. LactMed is there at the bottom, the link to that LactMed website. Again, there is an app that's free and easy to use. And here are some references, lots of references that you can look back on. Skip right through, and then just take a moment to plug the next webinar, which is Wednesday, May 5th. Jill DeFonso, an excellent RN at Maine Medical Center. She and I will be speaking about cue-based feeding. And then in September, I'll be speaking more about milk supply and what happens when it doesn't work out optimally. And then in November, we'll be talking about perinatal mental health and treatments for that, and how those can work or not work well with lactation. So more to come on those. So what do we have for questions, Kelly?
Yeah, great. There's a question about, do we have any data regarding the number of moms who decide to stop THC to breastfeed and continue breastfeeding after 3 or 6 months? I see moms often say they will just stop, but I wonder if this is actually happening, or do they just use and continue to use cannabis and continue to breastfeed?
Right, that's a great question, and we don't know. So not only am I not familiar with the studies on that, but we also don't know how accurate those reports might be. Like you said, they might say that they're going to stop. They might stop completely, or they might just be stopping for that first month after birth. And like I said, I've spent a lot of time on that Breastfed Cannababies Facebook group to learn what people are saying. And it's all over the board. It's all over the place, as you've also probably experienced. Some people who said that they stopped until after their baby was, or when they weren't breastfeeding anymore, or their baby was a year old. Other people were saying that they smoked in the delivery room or right after or the day after. So it definitely is all over the board. And then what they report is also ranging, but I would love to see more of that research. And in particular, moms who just use marijuana, no other substances, and are only using it in the postpartum period versus also using it during pregnancy or also using other substances. That's the research we need.
So there's a question about our references to THC throughout the presentation applicable to CBD products as well.
No, it's a different chemical. So we don't have any research that I'm aware of on CBD in particular in breastfeeding. So that's also a gap in knowledge. If someone is aware of that, please let me know. I didn't come across that. It's a gap in knowledge. We know that it has different effects on the brain. And so some people might think it might not be as harmful, but we just don't know. It's THC in particular that has received the research.
So those are all the questions I'm seeing right now, but we do still have more time. We've got about 5 minutes left. If people want to type in a question, I'd be happy to ask Kara.
Or even sharing your experiences and suggestions that you have for the other folks on the call, what has worked well for you, where you might be struggling a bit. I think it's nice to have a chance to hear from everyone else working with these families.
Great idea. I think it can be hard because like cigarette smoking, it may be overwhelming, and it may be, the thought that no matter what I say, they're still going to continue to smoke. So I'm not even going to address it. Mm-hmm. So I don't know how much work has been done in the cannabis world with that kind of concept. Like, if you are addressing it with patients, do they listen?
Mm-hmm. Right, and I think one comparison too is that alcohol is also legal, but we know that there are harmful effects, and it's something that you want to talk about. You don't want to just say, well, they probably won't stop. It's still something you want to talk about.
We've had a couple questions about the slides and resources. The recording will be posted on the perinatal outreach website, and we can post the PowerPoint there as well. Another question, we've been told by DHHS that marijuana use in pregnancy must be reported, but we've heard that some hospitals don't report because we would be reporting all the time. Just curious if people report. So I'm going to defer that question. So I think that's probably a good question to send to Ashley Olin, unless you want to take that, Kara.
No, I think it's just a matter of time before we get a little more guidance around that. And what guidance is out there now, I believe, is that reporting should be done. I know that that's, like I said, really tricky if it's one exposure that's reported versus heavy use. So my heart goes out to those of you who are in those situations.
So I have a question. I'm a prenatal school teacher for pregnant teens in my community. It's been a challenge to educate them on the effects THC has on newborns because they all know better. Is using THC during pregnancy irreportable to DHHS? And so again, yes, and there's more guidance coming on that. And then the final question is, I heard that it is safer for a mom to inhale marijuana than it is to ingest. True harm reduction ideas?
Yeah, that's a good question, and that I don't believe is accurate. So I'm reading that. I need to read that again. Oh, it just went away, but I think I can get back to it.
Sorry.
Is it safer for mom to inhale marijuana than it is to ingest? Not necessarily. So the half-life is shorter from what I understand when it's inhaled versus when it's ingested. So it may be in mom's system for longer if it's ingested. But I don't know the exact time difference there. I think it's still going to be in her blood and it's still in her breast milk. For how long and how much is still unknown because of so many different factors how much THC is in that product, what else might be in that product, how much is she actually using, et cetera. So harm reduction ideas, I think, so I can see how that could be considered a harm reduction idea if that was true, to say, well, if you're going to use it, you should inhale it instead of ingest it. I'm not sure that would be an accurate statement. So I think in general, just reducing the overall use as much as possible. And then it's really ultimately, I think, up to them how they do that. I think we can give some suggestions, and that's a good conversation to have with them. How do you think you could reduce the use? But again, I'm not sure that's accurate, that it's safer, or that there would be less in mom's milk if she inhales it versus ingests it.
So I want to be respectful of people's time, and we are at 1 o'clock. If people miss the information on how to get your CMEs, please contact Kathy Taylor. She's the one that sent out the Zoom link for today. If you have additional questions that were not answered, please do reach out to Kara or myself, who we're happy to answer these additional questions. So I want to thank everyone for attending and for being interactive today, and looking forward to the ongoing series. Thanks, everyone. Have a good day. Bye-bye.
I don't know if, I think those are great questions that were left there. So I don't know if C. Martin is still there. I'm not familiar with any follow-up research. It's a great question. That's what we want to know, is, are there any delays? And especially for those who received more THC than the babies who received or were exposed to less THC. And once it's federally legal, do you think hospitals would still be required to report it? I do believe so. I see Kelly's typing an answer. I think so, because it's still a substance that the baby's exposed to that we know could be harmful. If there's research someday that says it's not, that there are no long-term effects or short-term neurological effects, then that might be different.
Yeah, there's no differentiation between legal and illegal use anymore. That used to be in a prior version of the law. So the answer is just any effects, then those have to be a notification to DHHS.
I'm looking through the comments now. I can stop recording if that, or stop.
Sounds good. So we got a few people still hanging in there, warriors here.
Yeah.
We've had DHS tell us if a baby goes into state custody, the feeding parent may not supply milk until they test negative. This can be a shock to parents if they've been breastfeeding. That's still an area where I think the consistency is so important, because things change. And right. It would be nice to have a standard response to this.
Right, and we know that even if her urine is positive, it doesn't mean it's positive in her plasma or her breast milk. So that's where things get really tricky. If they're testing her breast milk, that, you know, that's one thing. But yeah, good question. I think I can stop sharing my screen. There we go. Now I see you guys. I wasn't seeing it.
Yeah. Good. I think, Kathy, you can stop recording.
Oh, yeah, I did. I've stopped. Oh, okay. I know. Was it